Well, hello and welcome to HIPAA Chat with your host, Steve Spearman. I'm Carol Fly with High Tech Answers, and today marks the debut of our latest program. In this 1 hour long HIPAA Chat, attendees, we're going to address your questions on HIPAA high-tech compliance, meaningful use and security risk analysis, mitigation, and more. Today's topic is meaningful use security core measure stage 1 versus stage 2.
Great.
Yeah, hold on one second. Let me just move to the next slide. All right. HIPAA Chat is sponsored by eFax Corporate, a brand of J2 Global Inc. J2 is a leading provider of Internet services through its two divisions, Business Cloud Services and Digital Media. To learn more, visit them online at www.j2global.com. And about our host, Steve Spearman. Steve is the founder and chief security consultant for Health Security Solutions. As chief security consultant, Steve provides HIPAA risk analysis services for clients and business partners. He also serves as a member of the Healthcare Advisory Council at Ingram Micro, as a speaker for COMP-TIA and a consultant for state regional extension centers such as CITIA and the Georgia HITRAC. You can contact him directly at spearman@healthsecuritysolutions.com. Steve, hard to believe our first HIPAA Chat is here. We've been talking about this, it seems like, for months, but actually it's probably only been the last 6 or 8 weeks. How are you today? I understand you're in New York.
Great.
Yeah.
I am. I'm out of town, and as usual, whenever I travel up north, I'm not packed. You know, it's 10 to 20 degrees colder here, and I didn't pack appropriately. But anyway, I'm getting by. So.
Yeah, I just came back from Seattle. I was there for 4 days. It rained it was, of course, overcast. It was beautiful the day I left, and of course, coming from Arizona, I had nothing but shorts and T-shirts on. I pretty much froze.
Yeah, I hear it rains a lot there. That's what I hear. So.
Actually, it's a breathtaking, beautiful city.
Yes, absolutely.
Yeah. Well, we're excited about today and about this interesting format for a Q&A. Just a couple things. I did notice, as did you as well, from the registration list that there were actually a number of questions that really weren't related to the security risk analysis, but really related to MU and stage 2 MU. So I want to let our audience know that starting September 25th, our own Jim Tate is going to be hosting a 3-part series, 3 weeks in a row, starting the 25th. All about stage 2 MU. So for those of you who had questions that were really germane to other aspects of meaningful use other than the security risk analysis and those core measure related to that, please go on hightechanswers.com and you can find information about that 3-part series. We do have actually a number of questions from the registrants, which was terrific to see, and then we're also going to try taking some live questions from our audience today. And when I say live, I think we're going to ask them if, or I'm going to try to unmute them and actually hear voices other than yours and mine. That'd be kind of exciting, don't you think?
Yes, radio.
Yeah, right.
I always joked I wanted to either be a black preacher, an Irish tenor, or a radio host. So I guess I fell short on the first two. So
here we are.
So here we are. Yeah, absolutely.
Your claim to fame.
So,
and again, for the benefit of our audience, some of you may or may not know that we actually have High Tech Answers as an internet radio website, radio program and show and station actually. At healthcarenowradio.com, where you can listen to all of our programming, and we'll be actually posting the podcast of this event, HIPAA Chat, on our radio station, and also getting out the recording to all of our registrants. And I think before we actually get into the heart of what we're doing, which is this sort of live Q&A. Talk radio. I think you had a couple things that you want to review before we get into the meat of this. Is that correct?
Yeah. And our official topic was around the difference between stage 1 and stage 2 with meaningful use, and in fact a number of the questions were directly, hey, what's the difference between stage 1 and stage 2 of meaningful use? And so we thought we'd just start off with a couple of slides. These are literally be our only slides today. But yeah, I thought it would be worth kind of covering this in a little bit more formal manner. And I do want to say that, like, when we take on this topic, one of the things that, and in fact it was sort of touched on in some of the questions that we've already received, is that, like, what's the difference between meaningful use risk analysis and a HIPAA risk analysis? And the answer is there is none. That will become more apparent as we kind of go through these next couple of slides. It's very evident that the intention of meaningful use, core requirement number 15 or number 14 for stage 1, if you were a hospital, was that you would meet a requirement that you were already supposed to be meeting, which was the HIPAA requirement for risk analysis. And so in stage 1, the language says conduct or review a security risk analysis in accordance with the requirements under 45 CFR 164-308A1 and implement security updates as necessary and correct identified security deficiencies as part of its risk management process. So that cryptic code in the middle of that meaningful use language is the Code of Federal Regulations. It specifically points to the first HIPAA security standard, which is the Security Management Process Standard, and of course the very first implementation specification for that standard is the risk analysis requirement. So, you know, these are HIPAA risk analysis, meaningful use risk analysis. They are the same thing, but Stage 2 does make some changes, even though it doesn't change the requirement for risk analysis. Go back to that previous slide real quick. And what it basically does, it has the same language essentially, and then it adds this stuff around data at rest. It says, including addressing the encryption, security of data stored in certified electronic health records in accordance with, you know, blah, 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 312 and blah, 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 306D3, and implement security updates as necessary. So it adds this other stuff in there. And so kind of how do we think about all this? Let's go to the next slide. And so one of the things to kind of note is what are those, we saw that it already referenced the same thing that the first one, that 308, which was to the security management process standard. The 312 reference is specifically to a technical standard in HIPAA for encryption and decryption, and that's under the access control standard within the regulations. The thing to note, and there's been a lot of confusion, a lot of people think that Stage 2 creates a new encryption standard, just like many people used to think that it created a new, you know, risk analysis standard. But really it doesn't. That reference is to the encryption standard, and without getting too much into the weeds about how the rules work, encryption is what's called an addressable safeguard. An addressable means that it has to be implemented if it's reasonable and appropriate. And just to make sure that we're clear regarding Stage 2, there's that other reference in that meaningful use language 306, and that actually is under the general requirements of the HIPAA security rules, and it describes the addressable safeguards. So basically, meaningful use Stage 2, the requirement, it says, hey, you need to be thinking about encryption consistent with the HIPAA standards, but HIPAA does not require encryption, nor should you think about it as being optional. It's based on that reasonable and appropriate standard. So now I give a whole presentation on this, you know, pretty frequently, but you know, there really is this, you know, it's not changing standard. It is addressable. However, it is evident that by adding it to meaningful use, that the ONC and others that crafted it thought, hey, you guys, we really think you ought to be thinking about encryption more than you probably are. So let's just take that standard seriously.
Yeah.
And the last bit here is that I really believe that Stage 2, that this language regarding encryption is actually the biggest burden is on the vendors themselves, because it does make some requirements for them about what they need to do to be certified. The EHR vendors have to deliver Stage 2 software in an encrypted state. It requires that the software requires administrative level privileges to disable encryption, and it adds this language around risk management. So that's really the right way to think about it. The main thing, and I still think the biggest burden, in this language is risk analysis. You guys, everybody needs to do it. You need to do it for stage 1, stage 2. It's a HIPAA requirement, and it's something that we ought to, think really seriously about.
And of course, that's basically what we're going to be talking about today. SRA. So we're gonna dive right into this and start with the questions that we got related to this topic from the registrants. If we don't get to your question, if we run out of time, or we don't get to your question in the Q&A in the chat using the tool on the right sidebar, please email Steve offline, and he's promised to answer the question. It is S. Spearman.
I'll be nice, yes.
And forgive the typo. It is my bad. It's S. Spearman at healthsecuritysolutions.com. I left off the H in health and had some wrapping issues, but
yeah, don't copy and paste.
Yeah, exactly. Yeah. It's like
it's not health security. So.
I'm still in vacation mode, so yeah.
We'll allow it this time. We'll allow it this.
All right, so I'm going to dive right in. So question number 1 is from Angela from Decatur, Illinois, and great question. And she wants to know what is this? I love the this. What is this protect data at rest quotation mark piece? Some companies sell the certified software for this, and some have nothing. Wanting to know how to protect data at rest, which of course is a key issue with encryption.
Okay, and I kind of touched on that on my opening spiel about this, but let me kind of clarify that along the lines of how that question was asked. Basically, the protect data at rest is a reference to the HIPAA security rules, and the rules have a standard. Well, it's a safeguard around encryption, and it's again it's an addressable requirement. However, the vendors, in order to be certified, and I think that's what the questioner is asking, in order for an electronic health record to become certified against the stage 2 standard, they have to meet the encryption standard of the stage 2 requirement. So, and whereas before they had to have certain functionality related to risk analysis and security generally, in this one, they've added and kind of upped their game related to encryption. The safe way to really kind of get at this is if you are using a certified electronic health record that is certified for stage 2, then that EHR basically had to meet the requirements I described. The databases had to be delivered to the customer encrypted, and they had to have functionality that required administrative access privileges in order to disable encryption. But the quick answer is if your EHR is certified for stage 2, then presumably that would have been something they had to do in order to get certified. The way the question was answered, it might have been getting at something like, hey, is there a solution or vendor I can get at that will tell me this? That's really not what this language is talking about. It's talking about the certification process required for the EHR vendors.
A little bit different, yeah. Question number 2 is from Karen from Sacramento, California. Is a single sign-on allowed? If so, is multi-factor authentication required? I'm saying that correctly, right? Authentication.
Yeah, right. Yeah. Let me say, if single factor was not allowed, then like 98% of all healthcare organizations would have to shut their doors to that, because very few, So this is there, but there is a caveat to that. So the answer is no, it's not required. So the way that the rules address this is there's a general access control standard. So one of the things that is true is that when protected health information is involved, you are never allowed to share your username and password. And this is obviously something that in our practice we kind of we go to some pains to find out whether people are sharing passwords. There's even a little bit of a caveat because that caveat is if protected health information is involved. It might be okay at the network level to allow some sharing of passwords as long as protected health information is not involved. But once you get at the application level, it's just never allowed. You've got to basically have a way to authenticate. And so that was the access control standard, unique user ID. There's also an authentication standard. These are all under the technical rules, and it's interesting how they kind of hang together because you can't know for sure that this person did this in the record unless everybody has adequate access controls. Now, having said that, there is one exception where it is now required to use multi-factor or two-factor authentication. And just for the sake of some of the listeners that may not be as technical as this questioner, is there three factors, what's called three-factor authentication. It's what you know, so that's what most people use as a single factor. It's they know their password. But there's also what you have and then who you are. So let me explain those. What you know is a password. What you have in the case of an ATM machine is a card. You have an ATM card, and that's so anytime you get cash out of your ATM, you're using two-factor authentication. You're putting in your card, which you have, and you're putting in, and then you're entering in your passcode, two factors. So the third one is, what is the third one? Who you are. Well, that means biometrics. It's fingerprints, retinal scans, things like that allow you to authenticate in the system. You're going to see more of that in healthcare. And now the one area that there is now, it's not a HIPAA requirement, but it's being required by the DEA, by the Drug Enforcement Agency, is that if you want to do e-prescribing, and there's actually a big push towards making it eventually required, if you want to do e-prescribing of controlled substances, I think that's class 3, somebody maybe can correct me that's here, but of narcotics, you have to use, according to DEA rules, you have to use two-factor authentication. So the answer to your question is no, except for the e-prescribing of narcotics. And in that case, you do need to use some sort of two-factor authentication. And if any of you out there want some suggestions about how to go about I'm a big fan of two-factor authentication. I like to see it even when it's not required. It's if you think about it, some of you are dealing with doctors every day. Ask yourself this question: how much do my doctors like having to remember passwords? Think
Right.
about that. Yeah. No, they don't like this at all. They hate passwords. And if you go to something where you could use like a proximity card with a simple passcode, doctors love that. They really like it. And it has the benefit of both simultaneously increasing security and increasing operational usability. Tap and go, and doctors love it. So get in touch with me and I can sort of give you some ideas about where you could look at those kinds of solutions. And again, you have to be looking at something like that for this new DEA standard.
Right. Carol from Greenville, South Carolina. How
Hey,
do
my
you...
hometown. I grew up in
No,
Greenville.
I knew you were going to say
Yes,
that.
I'm from Greenville. Hey.
Well, everybody kind of figured you were definitely perhaps in the southern region of the country. I think
Not from these parts. I got on the New Jersey Transit train, and I was looking this door, and I'm thinking, open sesame. I don't know how to get this door to open, and the train conductor, he laughed at himself. He says that button to the left. So anyway, yeah, I ain't from these parts, as they say. Anyway.
Well, she would like to know, how do we meet the security requirements for stage 1 by September 30th? Well, even I know that is that's going to be a challenge. And B, what can we do in preparation for stage 2 next year?
Yeah, okay,
That's
this is a good question.
task.
It's a tough one. So it is now what, September 12th. So I'm going to give you one answer to this question that is kind of obnoxiously self-promoting in the sense that if you are a small practice, we have a small practice solution for risk analysis where we could actually meet the requirement prior to the end of the month. And by small practice, I mean, maybe 1 or 2 physicians, maybe a little more than that. If you got, if it's a simple kind of operational thing we do, it's a remote facilitated risk analysis. If you fit in that category and you don't want to have somebody outside do it, you're going to have to learn real quick and then get it done, because that's just that's what you have to do. It has to be done prior to the end of the reporting period. So if you're in your reporting period, you just have to get on the stick and get it done quickly. Now, and we might be talking a little bit about the process for doing that. Now, if you're a larger practice, get in touch with me. I got to tell you, you might need to push your dates. It's going to be very difficult to do a complex risk analysis between now and in September. There are tools that are available. There are risk assessment tools available. I'm not a fan of any of them, really, but that you could look in the direction of looking at some of those tools. And but the main thing is that your instinct is right. It does need to be done by the end of September if you're shooting for a Q3 attestation. You gotta get it done quickly.
Yeah, very quickly. All right, Sue from Atlanta, Georgia. That's Roberta Mullen, my business partner. Yeah, up the road. That's my business partner. Is it required that all remediation of items identified be completed before attestation? That's a great question.
Great question. The answer is no. And let me kind of explain a little bit why. So first of all, the language says, and implement security updates as needed. So kind of vague, but the reason I'm pretty insistent that the answer is no is for two reasons. One is the ONC Guide to the Privacy and Security of Information Technology, the ONC Guide to the Privacy and Security of HIT, which was published April 2012. In their Myths and Facts page, they basically say, no, you don't have to. They just So the question is, well, since you have to do something, what do you need to do? So I think you just need to demonstrate some good faith demonstrate some good faith in fixing the most critical problems, and then make sure that you have the other identified problems in the security management plan. So security management plan is not mentioned in meaningful use, but it's actually the second safeguard after risk analysis, and you want to make sure that you document all those and that you kind of have a, hey, we'll deal with this in Q1 when we have the budget for it or whatever. And when we do risk assessment, we categorize them according to critical, high, medium, and low, and then even the controls, the parts of it that we recommend in terms of here's what you need to do to fix it, we put in as required, highly recommended, and beneficial. And so, there's certain elements of those where, hey, if we're saying this is really important, do those things, and then the things that you need to put off, just put it in your security management plan, and I think you'll be fine.
Yeah, right. Melinda from Boston, Massachusetts, my hometown, by the way. If combining data from two platforms for the 2014 attestation period, do you need to complete a security risk assessment on both? That's another really good question. Yeah.
Good question, and it's a good question, and it's a little complicated. But let me kind of try to take a stab at it this way. One of the things that I started off today's presentation with was a statement, and that was this statement. It was a statement that a meaningful use risk assessment and a HIPAA risk assessment are the same thing. So presuming that is correct, and I'm confident it is, the question is, what does a HIPAA risk assessment cover? So that's the first question, and what's the evidence for that? So first of all, a HIPAA risk assessment requires that you identify all of the risks that are present to the confidentiality, integrity, and availability of electronic protected health information wherever it exists. So and this would include your copy machines, your iPhones, iPads. You need to do a complete inventory of all your IT assets where protected health information lives and where it's being processed and viewed and transmitted and stored. And so the answer is that yes, if you've got active systems containing protected health information, they need to both, and everything else that contains protected health information, need to be included in your risk assessment. Now there's one bit of good news that I can say from that answer.
that's
Yeah, because I mean,
yeah.
it's like here, it's like, can I, you know, and so the person says, can I do A or B? And my answer is A and B plus C. So, you know, not necessarily the answer that I think Melinda was looking for, um, so that's sort of the thing is, yeah, risk analysis should look at all the assets that are, you know, containing protected health information. Now, let me say the good news, though, that there is a little bit of a silver cloud. The other thing that's evident, though, is that the rules don't require organizations to do a full risk assessment every year. In other words, that the way I put it is, if you did a risk assessment last year, let's say, and I'm going to go on the assumption that you did a good risk assessment, a little bit of a risky assumption, but let's assume that you did a good one that involved all of your assets, and assume that there was no significant changes in your environment. Well, then in that case, a review might be warranted. Now, the one thing that makes this kind of question was it Melinda? Was that her
Yeah,
name?
it was Melinda from
Yeah, Melinda. So the one thing, though, is because she's talking about moving from one system to another, that would be considered a significant operational change that would warrant a full risk assessment. So, so my advice to her specifically is do a full risk analysis and make sure that you include all the assets that are processing, viewing, transmitting, storing protected health information.
Okay. We have three of our registrants, Cynthia from Roswell, Georgia, Lizette from Longview, Washington, and Satyendra, hopefully I said that correctly, from Hayward, California. All three of them asked different questions, but really asking the same question, which is, what is the basics and process for actually conducting a risk analysis? And you've got some information to help them with that, correct?
Yeah. This is a really good question. So I've already kind of made reference to tools that are available, but so let me kind of go back a little bit to square one. So meaningful use harkens to HIPAA, as we've already seen. So what does HIPAA say? Well, HIPAA doesn't actually give you the step-by-step for how to do a risk assessment. So, but what does it do? Well, it says, as I said, a risk assessment must, you must identify the threats and vulnerabilities present, threats and vulnerabilities related to confidentiality, in other words, privacy, integrity. That's things like access controls and authentication, and availability, making sure the data is there when you need it, to electronic protected health information, wherever it exists. So that's what the HIPAA rule says needs to happen. Other than that, though, we get our best clues from like what's called the rulemaking in the law, where people are putting all these comments. And the thing that's referenced over and over and over and over in government documents is the NIST, the National Institute for Standards and Technology, has published multiple documents, but mainly it's called Special Publication 800-30, and that document is referenced in multiple government documents. Certainly, it's not you could use a different standard, a different methodology, and argue, as long as you're doing what HIPAA says, which is to identify the threats and vulnerabilities to EPHI, that would be acceptable. It's not like the NIST is the only thing that matters, but it's a good method. It's what I use. It's what many consultants use, and basically, so I'm going to really kind of go do this very rough, quick and dirty kind of like, here's what to think about way you might do it. This does very closely follow along kind of what's in the rules. So you want to do a complete inventory of all your assets. There are tools available to help you with this. If you have an IT vendor that helps you manage your network, they're likely to be able to do an inventory for you, and you're going to want to add things that don't come on that list, maybe your iPhones and copy machines, things like that. And then, there's a description of what's called information flow analysis, where you know where data is coming in. That could be something just sitting, from key people in front of a whiteboard and just sort of saying, here's where our data comes in. and just diagram those elements. How are those connected? And then a good idea is to pull an interface, do an inventory of all your interfaces. That gives you a good idea for how data is coming in the organization, how it's going out. Do a policy review. The single biggest area where people fall short in their risk analysis is policies. You may have, what otherwise would be a very secure organization, but if you don't have the policies that are required under the rules, then you're out of compliance, and if you're audited, you're going to fail your audit. You gotta. So I recommend do a policy review and what's called a policy map. That means making sure that you've got. You look at, hey, there's this regulation called sanctions. What is our policy that maps to that regulation? So.
Right. And if you Google NIST, obviously it comes up immediately, right?
Yeah,
right.
Yeah, absolutely.
Yeah.
Another one would be a security incident review. Like you should be, if you've got policies that you're following, you should have a security incident policy and procedure, and you just look and say, what have we had, that's gone wrong? Oh, we had that. We had that person just walk into our office and started walking around and looking at stuff, and he wasn't an employee. That would be an incident that you might document. Or look at your training materials. Look at from a technical standpoint, doing vulnerability scans would be important. What your wireless assessment, what your wireless environment is like. People should have a firewall, set up, preferably like a UTM, what's called a Unified Threat Management, and making sure those are set appropriately. Physical security, that like locks on doors and positioning of workstations. Look at your contingency plan, things like data backup. The contingency plan standard requires you to have a complete reproducible copy of protected health information. And then, job description for your security officer, looking at authentication access controls. You look at all these different elements. Encryption, what's encrypted, what needs to be encrypted, how are you transmitting protected health information, not just from like servers to clients, but like are you emailing PHI, are you texting PHI? Carol, I don't know if you run, but texting's kind of become a big deal. It's like people text anything today, apparently. But doctors do like texting, and it's great. I'm a big fan. But when it involves protected health information,
right.
It needs to be done in a secure manner. And then from all this data gathering, we kind of look, okay, how do we rank these risks, and then we generate a report that says here are the risks and here are the things that we recommend you do. This seems like a real mouthful. A couple of the self-assessment tools, I don't like any of them, but they kind of roughly follow these things that we've described, and can kind of help you get through that. But the go-to guide, for understanding how to do risk assessment is the NIST 800-30 publication, and it really kind of gives you. It's 80 pages long. It's very, very well written, but it's not. Most laymen are gonna,
That's what I've heard.
Tough to get through. Yeah.
Yeah, I've heard it's a lot to wade through if you don't know really how to appropriately read the language. Yeah.
Your accountant might like it.
Your accountant or your attorney.
Yeah.
Yeah.
Your attorney or accountant. They might.
Yeah.
It might be enjoyable read for them.
Yeah. You mentioned texting. It's like with all the acronyms in healthcare, it seems like that would actually be a perfect marriage. But that's a tough deal when it comes to securing PHI.
One of the challenges with texting is that people want to text PHI, but to do that, you should be encrypting those. But in order to encrypt anything, you have to have a way to decrypt it on the other end, which means your other user has to have, they have to have the same sort of texting tool. But people don't want to have to, like when they send a text to their daughter in college you got to load this encryption piece. So the way, like a lot of solutions do that, is that you have your standard texting tool, like your iPhone, iMessage capability, and then there will be another application that's the encrypted messages, and you use that when you're sending stuff messages. So there are a lot of tools. Tiger Text.
Yeah, right.
Imprivata has actually a free to try tool called Cortext.
EFACs are, check out EFACs
EFACs, oh
are,
great.
yeah,
EFACs has a
yeah.
great
They do.
solution.
They
That
actually,
really,
they actually do.
no,
Yeah, yeah.
no, that's I mean, and it's a real. The thing is too is a lot of people when they think about like security of PHI in motion, it's sort of off. They don't think about it. They don't think about
Right,
texting. You know.
right. Or BYOD, bring your own
Yeah,
device. You're not thinking about
absolutely.
that. Yeah.
Yeah, BYOD is like is that we're always having to have the discussion about, yeah, there's a lot of value for allowing people to use their own computers, but they still need to be governed by the rules
Right,
if it
right.
involves protected health information. So, and yeah, so that's great.
Yeah.
Yeah, so these are the kinds of things that you really should look at.
We're actually going to be talking about that on another event that we're doing next week with EFAC, actually, about 6 steps for securing BYOD, because it's a
It's a complicated thing.
complicated,
Absolutely.
huge
Yeah.
issue. You can go on hightechanswers.net and
Awesome.
you'll find it. Yeah.
Go there.
Go there. Go there now. Don't go there now. Go there
now,
after.
Yeah.
Yeah.
Well, go after. Absolutely.
Deborah from Richardson, Texas. Really, this is a really great question, especially I think for small physician offices, which is what is the biggest hurdle physician offices face to be compliant? I mean, obviously that's an opinion question. I mean,
I know this is a really, this is kind of a dear to my heart kind of question because I like this. I've already mentioned this small practice service that we provide. That's a remote facilitated risk analysis, and one reason I love that practice, that piece so much is because they feel so helped by it. They are just so like, how do I handle that? You think about a large multi-specialty, multi-location thing. They've got a whole compliance office, and a risk manager and an IT director, and that can kind of, sort of these things can scale. But when you're a small practice, it's really hard. So, the biggest challenge I think is knowing how to document your compliance. It's that, and I will say that the first step to compliance really is risk assessment. It's like understanding what you need to do. It should include this policy piece that we've talked about, and then I give a whole presentation on how to document your compliance because if you're doing the right things but you can't prove it, then as far as an auditor is concerned, you're not complying. And so that's kind of, and I think the challenge is that, oh yeah, right, another thing I have to think about and manage. And all I can say is, I'm with you, bro. With you, sister. With you, sister.
One more thing.
Yeah, like I really needed this. Yeah. So no, it's very. It's not easy. We try with our risk assessment because we provide a complete set of policies for our clients, complete set of security policies, and we have a policy map. We kind of help them get on their way to doing that, and we're even currently developing something that we'll include with all our risk assessments too. That it's a compliance folder, so it'll say when you have this happen, put your training log in this tab, and it kind of helps them do it. So the real challenge generally for the small practices is resources. They've got stretched and what to do. So, and getting help is a really good idea. And I really do hope. My heart is for you guys, those small practices out there, and we really try to really make it easy as we can for them. So.
Right. It is a challenge. Obviously bandwidth, the bandwidth is an issue, but no matter how big or small you are, but certainly for 1, 2, 3 doc practices where people are wearing multiple hats, it's a tough.
And they don't have resources. They don't have expertise. They've got ACA and ICD-10 and meaningful use and EHR adoption. It's like it's hard for them right now. And my sympathies are with them. And I wish I had a magic wand. But so I guess is prioritize and eat the elephant one bite at a time, and get through our current environment, because do think it's going to get better. I do.
Right.
I hope.
Oh yeah, you know, it, it's one of the things I think for a lot of challenges, it's really what I hear anyway, especially on the physician side, it's really doing security risk assessment the right way the first time. Do you know what I mean?
Yeah.
And yeah,
Yeah.
it's like any challenge.
Yeah, doing it, yeah, and then managing it, doing
And
it
managing
right,
it,
and
yeah.
then just kind of, okay, it's maybe an hour a week to devote to this, or and that, I know it seems like a lot, even that, but I mean, but it can be done.
Yeah,
So
sure.
yeah.
And we've definitely got some obviously we have a number of questions coming in from our audience. Some of them just generally, yes, everybody will get a recording of today's HIPAA chat. I sort of text everybody. There have been a number of questions, and nobody has said they want to be unmuted yet. So I might.
Come on, I won't
I
bite.
know.
I'm such a
I
nice
might.
guy. I don't.
Hey,
It's like,
Jim Tate, I know you're on the line. Can I unmute you, and we'll show our audience that this is a really friendly thing. So I'm going to unmute him and see if he's there. Jim, are you there? Jim?
uh-oh,
No,
awkward,
Oh, hey,
awkward side.
hey, Jim.
can you hear me?
We
Yes,
can
we can
hear
hear.
you. Yeah, we wanted to show our audience that the
Yeah,
live question
well,
is not scary, and
no, I've been enjoying it. And Steve, one of the things that you mentioned that I've been experiencing lately is that, especially for hospitals, we're down at the end of the 2014 year. The
Yes,
year for
yes.
2014 ends the end of this month. And you and I have both run across doing some mock audits where what is shown as the security risk assessment would not pass an audit,
Yeah.
and so there is some scurrying that's going on, or
Yeah.
maybe people are doing last minute review, and it's too late to get somebody from the outside to come in. You've mentioned a couple of different resources. Is there? I was just thinking as you were saying that. Is there anything that you've seen on YouTube where somebody just gives a 2-hour presentation about step by step?
I
Do
have not
this.
seen, I have never seen anything like
Yeah.
that. Where I tell you where I am like a wealth of information is that
Sure.
certain parts of this, like my thing is I can point people to tools, and you like for example, doing the inventory. One of the tools I point to that's free and does a very nice job is SpiceWorks.
Mm-hmm.
And given that inventory is such a big part of the risk assessment, it's like the first couple things you do. I mean, that will be a big piece of it. Some people do inventory and then they don't do anything with it, but at least that's better than not doing it. I mean, ideally you want to take it and break it down and ask yourself the question: does this asset produce or store or protect it? Things like that.
Sure.
But at a minimum, you want to categorize the different things in there and work with it. So,
Sure.
by the way, everybody, Jim is one of my favorite people. I just want to say, so call out.
Well,
I hope you'll join. We're doing a webinar together next week, and
mock audits. Yeah, for
yes, mock
hospitals, great.
audits.
Mark Hodges. Well,
Yes.
and speaking of those and around security risk assessment, I can remember when HIPAA first came around, and I was in a practice then, and we all moaned and groaned, and we had to do this HIPAA training and documenting it and all those kind of things. And now we have to do the security risk assessment, which is the electronic side of HIPAA, I guess.
Yeah.
But the real risk that I see, and I don't know what you think, but to somebody trying to steal information or hack information, they don't want the clinical information. They want the demographics for identity theft. They want that Social Security number.
Yeah.
And they want you. Yeah.
Yeah, I mean,
Could you speak to that?
the biggest threat from a hacking standpoint is anything that allows them to create fake credit card, get that kind of information. There is actually, though, sort of interesting, and I don't know if you heard, but did you hear about the community health system? Hack?
Yeah, CHS. That was a big hack.
4.5 million
Yeah,
records,
huge.
huge, and it was a lot of clinical data. Now, what the Chinese want with that, I don't really know. Maybe they're going to just get rid of all that and just focus on the Social Security number.
I mean, if you just strip, if they're medical records and they're individual records, I don't know, but maybe you just grab everything and then you just go back in parse out what you want.
What you want, yeah, yeah, and that's yeah. Yeah, there have been a few kind of because some diagnoses are embarrassing. There have been a few instances of extortion, like if you don't do X, Y, Z, we're going to reveal this to the world. That's been that. And there's also a type of hack where organizations, it's like CryptoLocker is one, where they'll literally go in and they will encrypt the databases of an organization and say, unless you pay us $500, we're going to make it so you can't get at your health data anymore. And it's happened to a number of clinics in the United States, one in Illinois and some others, and so that's an weird extortion. It's like they're using the security technology to basically hack your security essentially. So,
wow.
So that is another scheme that people have to be aware of.
Yeah.
So it's an interesting day.
Jim.
Well, yeah, go ahead.
Oh, I was going to say thanks for letting us unmute you. I was going to.
Oh no, I've got another question if I may.
Okay. Yeah, sure.
And so part of this kind of bleeds over to the breach notification stuff because. Yeah. I'm all the time hearing about somebody from a hospital that lost a laptop that had patient information on it.
Yes.
And so there's two parts to that. One is if you speak a little bit about breach notification, but also if people are walking around with laptops or it's bring your own device, how would that be documented in security risk assessment? Just through policies and things like that?
Those are two great questions. So obviously, when we're doing risk assessment, the probably single biggest risk we're looking for is a lost or stolen device that has a lot of data on it. It's like and let me say that with Omnibus last year, they changed the standard under which you have to report a breach, because it used to be prior to Omnibus that it was called the risk of harm standard. So you'd have to go in, do a risk assessment for purposes of determining breach, and then you'd have to say, is there likely that somebody's going to be harmed by this, financial, reputational, whatever? And then if so, you had to declare a breach. It was considered really subjective. Under Omnibus, they changed it so they basically point to the privacy rules. They basically say if there was an unauthorized disclosure of protected health information, and there are little minor caveats about, if it doesn't go any further, yada, 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 but basically you have to declare a breach. Even if it's a single breach, just like one record, you have to do annual reporting. If it's over 500, you have to report it within 60 days, you have to report it to local media, and so obviously we do that. So, but to kind of get to your question, is we look at the thing that we do to determine what needs to be encrypted based on that reasonable and appropriate standard has to do with the category of risk. Like, for example, a laptop is riskier than a desktop because it runs on battery, you can walk out of it, and presumably you might even still be connected to the network, whereas you unplug a desktop, you have to re-authenticate and all that other stuff. But the other big question is is there data on it? Like, you could set up a laptop so that it works exclusively through what's called a thin client, so there's no data on it. And I'm a big fan of thin client type technologies using VMware, Citrix, the RDP, remote desktops, so that you basically either minimize or just make it so there's no data on the device at all. Now you have to be careful because there are people that are set up that way, and even though most of their work is done through that connection, they still can save data locally, and and you have to deal with it. But if there's data on those kinds of devices, you need to be encrypting it, and that is something you can document and prove. To get to your question, Jim, is that if a device is stolen and you've, as an IT group, have gone to the trouble of encrypting it, there's documentation saying, hey, yeah, it's lost, but look, we did full disk encryption on this device, last November, and then you don't have to declare a breach. So encryption, that I will say one reason I point people towards full disk encryption as opposed to file and folder encryption is for this very question. It's actually harder to prove that the data that might be exposed was encrypted if you just use file and folder encryption. But if you're using full disk encryption, it's everything. So.
Sure. And one last follow-up question on the breach. So could you speak about breach notification? So if somebody loses that laptop, it may be kind of hard to know what information was lost. So what does the government expect us to do as far as notifying those patients?
That's a really good question. So sometimes your answer to the government is we don't know. We don't know exactly what was on it.
Okay.
It depends on the type of organization and thing. But if you can recover the device, you can do forensics. You can actually do forensic analysis and determine what might have been on it. There are also tools there are tools that as simple as Active Directory to more complex tools that can keep a record of what's on a machine. And those tools can sometimes help you do it. But sometimes you say, I don't know. You say, we know it was a lot of stuff and we're reporting it, but we don't know exactly what.
Okay.
And but you are actually required, I mean, when you're doing that risk assessment, to the degree that you can, you need to find out what was on that information. Another reason to use thin client, if you had if you go to thin client, and when I mean that could be VMware Citrix, but there's actually a whole class of client type devices that would replace desktops, and they cannot hold data at all. They can't hold data. You could literally take a thin client, unplug it from a hospital, nursing station, and go give it to a homeless guy. There's no data on there. So I wouldn't recommend that. It's an asset, but literally it would not be a breach. It would not be a breach. There's no data to be reported.
Right.
All
right. Jim, thanks so much.
Thanks.
And by the way, thanks. Bye. And speaking of Jim, we've had one of our audience members ask about the mock audit event. Actually, you and Jim are doing an encore event. Just real quick, it's next week. It's next on the 18th, I believe.
Thursday. Yeah, I think it's Thursdays.
Yeah, on the 18th. So if you go to hightechanswers.net and you'll see a place where we list all our webinars, upcoming events, go ahead and click there, and you can certainly learn more about mock audit and MU and from the hospital side, and security risk analysis. Also, a couple more points because we've got a few more questions related to MU, specifically MU, not related to these particular core measures related to security. But Jim Tate, who you just heard from, has got a 3-part series coming up starting September 25th. Again, hightechanswers.net. Go there, look under webinars, so you'll see that. And then we had a couple people ask questions regarding software for BYOD. EFAC's our sponsor. They have a product called Keep It Safe. We're doing an event with them next week on the 17th, actually, that looks at how to secure PHI on BYOD, acronyms.
Bring your own device.
Abound. Yeah. Got time for just a couple more questions before we exit here, and nobody wants to be unnice, but yeah. So Dan has actually asked a couple different questions, and he didn't chat back to me. I would like to have unmuted him, but his last one is kind of feeds right into what we're talking about from an audit standpoint, and that is, what liability do you have if you do a security risk analysis for a practice and you fail an audit?
That is a really interesting question. That's an interesting question. So there's potentially professional liability for that, and actually we have a little bit that we can point to in the media about this, and then my answer is ultimately going to be unsatisfactory. But everybody heard about the Target breach last year. Well, that breach, Target, because of the nature of the organization, they have to do risk assessment, and theirs was done by a very large, reputable security firm, and that firm has been named in a class action lawsuit related to the Target breaches and so the answer to that is that we'll see what happens at Target. In healthcare, I'm not aware of any case law we can look at where it's probably only a matter of time, and it'll be another consultant, not me, I'm sure, but that was just a little attempt at humor, but
I got
anyway, yeah, we got that, yeah.
Yeah.
We sort of don't know, but there is definitely potential liability. I mean, and I hold professional liability insurance for that purpose, as any good consultant should. You know, I think my kind of charge to consultants is do a good job, be thorough. You know, if you know, consistent with you know, research. You don't have to be you know, you don't have to be swabbing you know, desks and you know, doing you know, getting out your agar and you know,
right.
You know, but you need to be doing enough, you know, that where you can have a reasonably good chance of you know, doing that. Now let me say one thing. For any outside consultant, there is no excuse for failing a meaningful use audit. And one of the points that Jim and I have talked about is that these are desk audits. I've got many customers that have been audited, and they see our report and they've never been questioned. I mean, and I think it's possible because I've seen enough bad audits done by third parties, but you know, their standard, even though you know the standard of what needs to be done is really the HIPAA standard, is that they're just not looking that deeply. They want to see good faith. They want to see. They like to see a third party done it. They like to see an inventory. They don't like to see a checklist only. You know, they want to see a real compliant. You know, they want to see that you've uncovered risk and that you identify those risks. You know, but you know, so I wouldn't. You know, if you're a third party, you need to you know, do a good job.
Yeah, that's
that's kind of an unsatisfactory answer, but
yeah. A couple of people asked about those upcoming webinars where you're going to be with Jim next week on the 18th and the event with EFACS on the 17th for BYOD. If you go to hightechanswers.net, the URL is www.hightechanswers.net. You'll see on our top navigation a link to all of our upcoming webinars. Believe it or not, we are all out of time today. Steve, I think our first HIPAA chat was great. We've getting some good good feedback here.
My radio career starts.
I know.
In earnest here,
I know.
So,
we're gonna get some live questions here from real voices, I'm sure, in our next event. For more information about Steve, please visit his website www.healthsecuritysolutions.com. His email address, again, my bad on the misspelling, it is healthsecuritysolutions.com. S. Spearman. A couple of you actually asked about pricing for what he was talking about, so please email him directly. I'll make that correction when I email you all the recording. To learn more about our sponsor, EFACS, visit www.j2global.com. Again, we'll be talking with them next on the 17th next week about this issue of HIPAA security on BYOD, bring your own devices, and why that's such a huge impact. You can also, we'll be putting this recording podcast on our internet radio station, healthcarenowradio.com. You can check that out in a couple of days. And of course, please join us next month for HIPAA Chat. We are going to be doing a series of these once a month, and we'll get more information out as we figure out the topic and a time show. Steve, enjoy your trip back from New York, and I just want to thank everybody for today's participation. We'll see you on the next HIPAA Chat.
It was fun. Thanks.
Bye.